time to start this webinar. So most welcome to this webinar on AI in healthcare, big reward, equal risk. My name is Nihlén, and I will be moderating the discussions. And so that you know, this session will be recorded, but we will not put the discussions in public display. So only the presenters will be, the recordings will be put on public display. This is the second webinar in ethics from the Center for Research Ethics and Bioethics. First one was about AI in research, and now we focus on AI in healthcare and the ethical questions that this gives rise to. And the plan is, as I suggested, that we will start with presentations from Nihlén Fahlquist and Viberg Johansson. So without further ado, I will give the word to Jennifer. Please present yourself.
Thank you very much, Nicholas. And my name is Jennifer Viberg Johansson. I'm super happy to see so many participating in this webinar. I'm Associate Professor in Medical Ethics and work at the Center for Research Ethics and Bioethics at Uppsala University. And I will present today AI in healthcare together with my colleague Jessica.
Yes, and I'm Jessica Nihlén Fahlquist. I'm Associate Professor of Practical Philosophy and Senior Lecturer in Biomedical Ethics at the Center for Research Ethics and Bioethics.
So let's start the presentation. So AI in healthcare has a lot to promise. So here I have listed a few examples where AI could be of use. So we can use AI in medical imaging, for example, or in gene analytics or drug discovery, and the list can be long. And what they have all in common is that they want to improve efficiency, provide better care at a lower cost, or maybe streamline tasks and reduce waiting times, or maybe more equal access to healthcare, reduce stress among practitioners. And it's even urgent, needed, because predictions have been made that by 2031, nearly 50% more people will be at age of 80 or older, and 80% of them will be living with chronic disease. So this required additional 85,000 healthcare workers. So maybe we really need AI for our healthcare situation. But we need to think about ethics, of course, and that's why we're here today. So over to you, Jessica, about AI in philosophy.
Yes, so there has been a lot of research in philosophy about AI during recent decades, but it's been largely focused on philosophy of mind, so questions of intelligence and consciousness and whether AI and how it could be compared to human intelligence and consciousness. There's also a lot of discussion on robots, the use of robots, care bots, for instance, and military robots. And lately we've had a lot of discussions on AI assistants like ChatGPT and similar tools. And there has been a lot of attention in the media about how people use AI assistants, even as friends, relationship therapists, etc. And the problems and problems associated with that. Also, of course, in professional contexts, how we use it. But we are focusing here on AI ethics in a healthcare context, and that's algorithms used to predict disease, analyze images, and suggest probabilities, diagnosis, and or treatment, as Jennifer was talking about before. So it's a bit different. So Jennifer, you could switch. Yes. So, and from my perspective, working also as an ethics advisor in a real medical project going on as we speak, it's important to analyze the ethical issues from start. So already in the research phase, in order to look at the ethical questions that will arise in actual healthcare when we implement the AI tools. So I think both Jennifer and I want to see the whole process and focus on the whole process. So the research phase, the development phase, and also the implementation phase. So it's important to look at all of these different parts of the process. Yes, so, and when it comes to AI in medical research, if we focus on the first part of the process, it's a bit messy, you could say. There are different perspectives that come together in this area. We have research ethics because it's research being conducted. We have medical ethics because it's the healthcare context, the medical context. But we also have ethics of technology, the ethics of technology focus, which is a different branch of applied ethics, if you will. So ethics and AI in medical research involves all of these different perspectives, in my view. And when we talk about medical ethics, which we are very much used to working in healthcare and healthcare ethics, the focus is on the doctor-patient relationship, or the nurse-patient relationship too, but very much the doctor-patient relationship as an individual relationship between two people or more, but a very small context. And this is well established in healthcare, medical ethics. It's institutionalized and formalized through law, recommendation, and guidelines. And it's basically about protecting individuals and the rights of individuals. And the way that we analyze medical ethics today is very much based on principles, even though that's not the only aspects or tools that we use, but very much principles of medical ethics. That's sort of the foundation of medical ethics today. You could change. And in medical ethics, when we talk about principles, it is common to talk about these four principles that are discussed a lot in the literature and applied in research as well. So we talk about autonomy, the right to autonomy, the idea being that we are able and have the right to determine, to make decisions about our own life. The notion of informed consent is based on the principle of autonomy. We also have principles of non-maleficence and beneficence, do no harm and do good, and the principle of justice, which is about equal rights and prioritization of scarce resources. So these are the basic principles that are commonly used in medical ethics discussions. So you can change. Research ethics, it's quite similar to medical ethics, and it evolved during the same time period. It's also about rights, protecting individuals, not using human beings to for scientific progress. And there are additional principles, of course. And it's also institutionalized and formalized through law and ethics approval system. In Sweden, we have the Ethical Review Authority, etc. So it's institutionalized and formalized as well. So we have medical ethics and research ethics. And I think it's important to emphasize that just because a certain or a research project is legally accepted, that it is approved by the authority and according to the law, that does not necessarily mean that it is completely ethical, acceptable, or that there are no ethically problematic aspects of the project. And it also doesn't mean that it's socially accepted. So the research could still be ethically problematic or complex, at least. So ethical normative analysis is needed throughout the process for acceptability, justifiability, and stakeholder input is needed also for social acceptance. So we need to think about the normative issues and the justifiability, but also the societal acceptance. So these are two important aspects that sort of go beyond the legal system. We could change. Yes. So we have medical ethics, we have research ethics. The third branch, if you will, of applied ethics that we need to look at is the ethics of technology. And it's not a big discussion in Sweden, but there's a lot of discussion in certain other countries about ethics of technology. And in ethics of technology, the theories involved in that branch started to be developed very much through since the last 20 or 30 years. And the idea was that we need to focus not just on an individual context when we discuss ethics, we have to focus on societal and environmental aspects as well. And this area of research is not as widespread and well established as medical ethics or research ethics. It's only taught at some Swedish universities or to some degree in certain universities or engineering programs, whereas medical ethics is taught at all medical doctors programs. There's not a similar thing for engineering programs. The idea here is very much that ethical analysis is needed before technologies are introduced large scale in society. So it's not enough to, as we have been in throughout history, discuss technology when it's already there. Think about cars, for instance, road traffic or nuclear energy. We have discussed it when it's already there, and yeah, discussing benefits and risks. But we need to discuss it before the technologies are introduced, so throughout the development of the technology. That's the basic idea. And it's not institutionalized or formalized at all to the same extent. So it could change. And in ethics of technology, although it is not as structured and I don't want to say unified, but more unified as medical ethics is. But there are theories, there are approaches, there are methods, but not as easily structured as with the principles of biomedical ethics. There are ideas and theories about value-sensitive design, for instance, to include ethical values throughout the process, throughout development. There are also ideas about responsible social experiments, and the researchers then talk about introducing new technology in society as a form of experiment, a form of social experiment, claiming that we may need these experiments, but we need to do the experiments responsibly. And there's a comparison there between pharmaceuticals and new technology. So whereas pharmaceuticals are tested in so many steps, so many trials, technology is not tested in steps in the same controlled way. So we need to think about responsible social experiments. Ethical parallel research is doing the ethics research in parallel with the technological development. Ethics of risk, ethics of socially disruptive technologies, and ideas about problem of many hands, that when we talk about technological development, there are so many different actors involved, individual and collective, that it's hard to distribute or establish or think about who is responsible for what. So there are a lot of notions, theories, approaches, but the underlying idea that's common in all of these is that technology is not value neutral and it's not deterministic. There are values involved and there are people making decisions concerning values, even though they may not think about that as values, like justice, for instance. you could move on. So, and when we talk about AI ethics, this area has been discussed in terms of principles as well, and this has been recently codified in law in the European Union. But even before that, there were a lot of documents talking about principles of AI ethics, principles of trustworthy, responsible AI, and some of the principles that have been mentioned in these documents and that we have agreed on, many countries at least, is human agency, privacy, transparency, accountability or responsibility, and fairness. But my concern is, how should these principles actually be applied in the context of AI in medical research? So that's one of the challenges in this area. And we have all of these principles, as I said, and I wanted to look specifically at one of the principles and see what are the challenges in applying just one of these principles. So I thought the principle of fairness and non-discrimination was such an interesting principle to look at. Yeah, and in the project that I'm involved as an ethics advisor, these issues do arise. So that's why it's important to how do we apply this very, very good idea that AI should be fair? How do we apply that? Yes, Jennifer. So when it comes to fairness and bias and non-discrimination, I think probably most of us here have heard about the risk of there being biases in AI applications, and these could be biases and prejudices just transferred from our regular lives or society at large, the bias and prejudice that we already have about people and how we group people. But it doesn't have to be that obvious. The AI model, the result of the AI model could have fairness implications, even though we have had the best of intentions and trying to avoid biases being transferred from society. So, and this is based on how the data is representative or not for groups and individuals. So an AI model could potentially have a positive effect on the health of the majority because the data is based on the majority. And it can have no effect or a negative effect on the health of some minorities if those minorities are not represented. And from a strictly utilitarian perspective, this doesn't have to be a problem because, as Jennifer said in the beginning, what we can do is to become more efficient. We can maybe save more lives. We can use our resources in a better way. We can maximize health. So then it wouldn't necessarily be a problem that certain individuals or certain minorities that the AI doesn't have an effect or maybe even a slightly negative effect for some people. Yes. And when it comes to discrimination, and it also has to do with the selection of groups. Which groups are we looking at when we're looking at data? So certain groups are predefined in most of this kind of data. If you think, for example, about register data. Biological, sex, chronological age, etc. But some groups are excluded in the data, and sometimes for good reasons. Like in Sweden and I think most European countries, we don't use race or ethnicity or gender identity and sexual identity. We don't use those groups, and they are not represented as groups in the data. And that is for discrimination reasons, for reasons of discrimination, that we don't talk about ethnicity or race. Whereas in the United States, as most of you probably know, they use the concept of race and ethnicity. And both of these ways of thinking and organizing, structuring research, both of these ways are doing it for fairness reasons, for non-discrimination reasons, to include or exclude those groups. But one problem is that, and in the project where I'm working, there's if the data is based on registers, for instance, and the groups are already there, we may have a problem, an epistemic problem, because we don't know in the future which groups will be important for health. For example, transgender. We don't have that group categorization in the registers, and we don't know in the future. It may turn out that these are important factors. Ethnicity, we don't really know. So yes, that could be a problem. Selection of groups. You can move on. It's also important to make decisions regarding how we define fairness. Even for scientific reasons, we need to have a definition in order to know if it's more fair or less fair than before. Fairness can be seen in terms of a negative duty to refrain from discrimination, or it can be seen as a positive duty to achieve a goal, for example, equality in healthcare. Or does fairness require that we take positive measures to achieve equality and equal capabilities, for instance? So it could be seen in terms of refraining from something, or in requiring actions to do certain things. So we need to define, we need to describe what we are actually doing when we're trying to achieve fairness. Also, another question is, are we talking about procedural justice? So the processes, are the processes fair in which we take decisions? For instance, as Jennifer will talk about, who is considered to be a stakeholder and who is actually involved in making decisions concerning the introduction of AI in healthcare? Or are we talking about the outcomes, distributive justice? What is to be distributed? So we have these different this distinction as well. Yes. So I think because of all of this, all of these different aspects and the definitions and descriptions that we need to make, the decisions that we need to make, we need, and also the messiness of having these different areas being relevant. We need to have interdisciplinary communication, medical researchers, technology developers, etc. We need to communicate and we need to collaborate, which sounds really good and easy, but it's not as easy in reality as in theory. But we need to do that. We need to discuss and clarify what are the implicit values involved, what are the desirable values, and who are the stakeholders. For instance, in relation to the concepts of fairness, is fairness implicitly defined in terms of reduction, mitigation of bias? And could it be defined in a different way? And as mentioned before, who is a stakeholder? Hospital staff, patients, relatives, the public, and when and how should stakeholders be consulted? Yes. And I think this also implies that we need to think about top-down versus bottom-up approaches, and I think we need both. So if we have principles and think about them as having to be applied, it's a top-down approach. But ethics, as it has been described here, is not just a set of principles. It's not the end of ethics. It's not the case that we have principles, we apply them, and then we're done. We also need a bottom-up approach to see what issues actually arise in the research phase, especially in the research phase where there's a lot of uncertainty and lack of knowledge. Yes.
Yes, so I will talk about the stakeholder perspective for a while. I have done 2 studies where I interviewed women in in a mammography setting, and also the radiologist working with an AI for the screening process. So if I would summarize the woman's perception of participating in mammography, I would say that finding cancer is more important for them, regardless of how. So they had the focus on finding cancer and not how it is found. However, they had a desire of human involvement. But they also emphasized that they trust healthcare, and therefore they trust if healthcare use AI. They discussed a lot their willingness to share data, and that varies across routine care, research, or industry. So in routine care, they don't find that problematic at all. And for research, a little bit more concern, and to industry, they were more hesitant to share the data. And that can be very valuable for the development of the AI. I could see two patterns when it comes to their description of tolerance for error. So some of the participants, they found it unacceptable for technology to make mistakes. They said things like AI needs to work well, have high reliability, and should not make errors. That they will feel bad or disappointed or even tricked or fooled if the AI made mistakes. And they found it more acceptable for radiologists to make mistakes, that it's human to err. Another perception was more like what AI is about, that it's statistical predictions, and that no system is always accurate. And when I interviewed the radiologist, they were overall optimistic, and they didn't feel that AI was a threat to the profession. But they were concerned about if the education doesn't adapt to interpret AI-generated result. They said that needs to be trained. But they were also scared that the radiologists may lose their skills, or that new radiologists will not build up the skills that they have reached through looking at a lot of pictures. And they had also critiqued to the AI that was used during this time, that the AI was not able to take into account historical images and distinguish between cancer and scar tissue. And if we take a look at the literature, the overall literature about factors that influencing whether a professional will accept AI or not, we can see that healthcare personnel if they believe that AI adds value, they accept the AI more. And if the perceived effort, or if it fits into existing workflows, if they are also encouraged by key individuals, that matters. If they have access to necessary infrastructure, or if they perceive it as a threat, that matters. And also if it aligns with personnel's ethical values, their willingness to try, and their ability to use the AI. Those are factors that matters. Is this something you recognize, Jessica, for the research you have done?
Yes, we've done interviews with personnel at the emergency department, and I think it's similar to what you've seen in your studies.
And I find a mixed method systematic review on patients and their general public attitudes, and it varies a lot. So many, between 3 and 25%, had no prior perception of AI, and this was 2021, so maybe that has changed until now. Overall, they had positive attitude to AI for screening and treatment, but negative when it comes to high-risk areas as autonomous surgery or antibiotic dosing. And they preferred AI as a support tool and not as a replacement for healthcare professionals. And that is also similar to my result with the women in mammography. And I'm very much looking forward to my next project. I can see some of my colleagues are in this webinar right now. And we got money from Nordforsk, and we will test how people define, or how they how they define fairness, but also test the accuracy of a AI. And for instance, we will ask participants in the general public in 5 different countries if they prefer model A over model B, and then we will change the content of fairness and see what people prioritize when it comes to fairness. I think this will be very interesting, and then we can further discuss the fairness concept in AI. So many different stakeholders, like Jessica was talking about, play a critical role for successful implementation of AI. And I have now talked about the user perspective, but we have also other perspectives. So the AI developers and the regulatory authorities. We have the healthcare system through the procurement officers, and we have also the educators and at the universities. And we have legislation that can help us to put good quality AI product in healthcare. So much is outlined in the AI Act and together with medical device regulation. I will give you some example of the content of AI Act, for instance. So we have Article 9, where the provider needs to show the risk management system and data governance. They need to have technical documentation and record keeping. They need to have transparency and provision of information to deployers. So a lot of things are on the demand side. But again, we need to go from theory to practice. So this law needs to be put into practice. So in the end, we want safe and effective and fair AI technology, and we have the legislation that provide this framework, but we need to make them practical. So legal requirements need to be translated and into operational standards. So healthcare organizations play here, I argue, for a critical role in AI adoption. So ask for clinical relevance, context-specific documentation, transparency in the system design, and clear definition of quality. For instance, diagnostic accuracy, patient outcome, including considering, for instance, fairness. And I think that the procurement becomes a tool for quality. So if the healthcare doesn't ask for those things from the companies, that there is a risk that we will have a bad quality AI tools in healthcare system. So our recipe for success is to define what is a fair AI or other ethical values that you consider is on stake, what it means in practice, so not only fancy words, and embed this principle early and carry them through research, through development and the implementation, and for instance, as I argue, the procurement process. So thank you very much for listening.
Thank you very much, Jessica and Jennifer. So we have time for questions. Please raise your Zoom hand if you want to